not in the house. I don't recollect seeing you there. I seldom attend.
Previously on Poldark.
I love Easter.
Please go.
What is immunotherapy in the world of cancer? It's also called biologic therapy. It is a type of cancer treatment that boosts your own body's natural defense to fight cancer and improve or restore the immune system functions. Scientific advances are revolutionizing the approach to targeted therapy, and all are leading to very personalized medical treatments. So during this next hour, you're going to have experts answering your questions about immunotherapy in cancer care specifically. Again, we have 3 oncologists on, so there's a lot of cancer questions we can ask as well. Stay with us and think of some questions that you want to call and ask us about this evening. The telephone number is 881-0013. You can also ask live questions because we are streaming live on Facebook. Just go to the search engine or the search bar in Facebook and search KCOS TV, and you'll see this program again live, and we'll have somebody there answering your questions live as well. This evening's program is underwritten by Texas Oncology. We here in El Paso know them as the El Paso Cancer Treatment Center. We also want to say thank you so much to the Texas Tech Paul L. Foster School of Medicine for providing the medical students who are going to be answering your phones. And today we have Nikita Lobo, and we also have Aaron Pine. So these are the 2 medical students that are going to be answering the phones, taking down your questions, and then bringing them our way to the docs. We also want to say a huge and special thank you to the El Paso County Medical Society for bringing the show to you for over 21 years. I'm Catherine Berg, and you're watching the El Paso Physician.
Funding for Masterpiece is also provided by Farmers Insurance.
Thanks again for joining us. This is, for me, a relatively new show. Dr. Valilis said that we've been studying immunotherapy for over 30 years, but really we're just now in the last several years finding real people giving us real stories of how beautiful this treatment is. So with us this evening, we have Dr. Shiba Tano, who, and all 3 of them are medical oncologists. So we have Dr. Shiba Tano, we have Dr. Miguel Albino, and we have Dr., I'm just going to call you Pana Valilis. And so they have been on before. All 3 are veterans. And tonight we're talking about cancer. But we're talking about new stuff. And we're talking about treatments. And we're talking about targeted and how every individual person has their own type of cancer. And even if it's breast cancer, it's still 50 different types of breast cancer, etc. So I would like to kind of start the program off. Dr. Tano, if you can introduce yourself, maybe talk 30 seconds or so. Are you from El Paso? Did you come from somewhere else? Do you have a loved one? Do you have a puppy? Doesn't matter. But in general, we'd like to give people at home a picture of who you are so they kind of know what questions to ask of what doctor. Dr. Tano?
Hi, I'm Dr. Shiba Tano. I'm originally from Houston, but my husband, Vil, he is also a physician. He brought me here, so El Paso is my new home.
Way to go, Vil.
Yeah.
All right.
And we have an 8.5-month-old son, and I have an amazing extended family here. And so they've been an incredible support. And it's been great just kind of putting down roots and just getting to know El Paso a lot better. So
8.5 months. Are you sleeping well at night?
Yes, we're getting there.
Good job. Good job. Dr. Albino, how about you?
Hi. Well, my name is Miguel Albino. I've been in El Paso. I've been fortunate enough to be here for almost 3 years now. I came from San Juan, Puerto Rico originally, and I have a lovely family at home that includes my beautiful wife, Karina, and my 2 beautiful daughters, Catalina and Cecilia, who are 5 and 3 years old this January.
You guys have little ones at home.
Yes.
Dr. Valilis, he starts cracking up. I don't have little ones at home. Dr. Valilis, how about you?
I'm a veteran.
You're a veteran.
I'm here in El Paso for the past 22 years.
Nice.
And I like this place. And I have a daughter, Eva Maria, who's an intern in Johns Hopkins in Baltimore. And also I have my wife here, who's a dentist.
Very nice. Wow, you guys are very accomplished. I love that we talk about families every now and again. I have a 16-year-old and 21-year-old, and those poor kids, they get talked about on the show all the time. But it's not because they're great kids. It's like, hey, my 16-year-old, he had lice back when he was 12, and it's always embarrassing stuff. But what I'd like to do is start off this program because we're talking about treatment specifically tonight. And if we could, and like for all 3 of you to kind of answer this, the traditional treatments have been I'm going to go back years. You know, usually surgery, maybe chemotherapy, then radiation, but immunotherapy is kind of new. So Dr. Tano, if you can kind of start off with, and you're super young, so I feel I'm 51. Again, that's where the kids come in too. So we've been doing the show for a long time. This is new for me to be able to talk about in such a way that we're going to talk about it today. So you coming on board as a young doctor, this is something you've been dealing with since the beginning of your studies, I'd imagine, correct?
Yes, I would say so. And so I guess in order to properly talk about immunotherapy, I guess you would probably need a little bit of history about cancer cells and chemotherapy in general. And so essentially how does a cancer cell form? It's essentially, it is behaving without any regard to the previous restrictions for cell growth. It may look like a breast cell, but a breast cancer cell is one that doesn't obey rigid guidelines, and it just sort of breaks through barriers and it grows inappropriately. And so chemotherapy takes advantage of that fact that these are rapidly growing cells that don't obey the rules. Right. And so they targeted cells that divided and multiplied. And so traditional chemotherapy targeted those rapidly growing cells, but they also targeted normal cells that are supposed to do that, like your skin, like your hair, your nails. And so that's why a lot of the common side effects are notably affected by chemotherapy. So immunotherapy is an opportunity to be able to target a cancer cell that's not necessarily one that's, it may be still rapidly dividing, but it's not going to affect your hair. It's not going to make you nauseous and things like that. So it's actually a very good benefit to have.
And on that note, and Dr. Albino, I'm going to switch this one to you. And again, because all three of you are talking about the same topic, feel free to jump in, add, etc. So when we're looking at, and it's targeted because everybody has their own immune system, and it could be compromised or not. So when you're looking at how to treat somebody with immunotherapy, and maybe even throw out a case study without a name, and talk us through how that would be an option for a certain type of cancer.
Yes, absolutely. There's different kinds of immunotherapies, such as there's the same way there's different kinds of chemotherapy, and it's basically going to depend on where's the cancer, basically.
Okay.
So I'll throw out an example of lung cancer,
okay, good.
Which is a good example because of all the advances recently in lung cancer. So immunotherapy is not for everybody with lung cancer. It's for certain types of lung cancer in a certain stage. So basically, the workup is similar. We do a staging, routine workup to find out where the cancer is, how advanced it is, and then maybe the patient will qualify for immunotherapy. We also have to take into account that there are some lab studies that need to be done to see if the patient is susceptible to immunotherapy and will qualify. Based on FDA and NCCN guidelines, which are the guidelines we use to treat patients.
And when you're talking about, and let's take lung cancer a little bit further, and this one is close to my heart. I lost my mother 24 years ago to small cell lung cancer that then spread to the brain. So there's a very large difference in treatment, at least at that time, and I understand going forward too, between large cell and small cell when it comes to lung cancer. Which cancer is more reacts better to immunotherapy versus any other type of therapy?
A very good question. I'm sorry for your loss, by the way.
Thank you.
You're welcome. Definitely non-small cell lung cancer. These patients are going to be more susceptible to immunotherapy.
And that's the more common type,
yes,
correct? Large cell, or you say non-small cell?
Non-small cell, yes, significantly. Okay. Small cell, there is a role for immunotherapy, but only for patients with very advanced disease who have failed chemotherapy, since chemotherapy is very active in this kind of cancer, but the response is not as robust. So in non-small cell lung cancer, we do have a role for immunotherapy, even as a first line, as recently as a couple of months ago, approved for any patient with stage 4 disease will now probably receive immunotherapy as their first treatment. And we also use it in other settings. In stage 3, for example, after you have undergone hopefully curative chemoradiation therapy, a maintenance regimen of immunotherapy that improves the patient's outcome and survival significantly.
So here, Dr. Valilis, let's go to you now and talk about, because chemotherapy is from the outside, radiation is from the outside, surgery is from the outside, immunotherapy could be from the outside, but could also be internally somehow put together from your own immune system. Right. So I think that's going to be the big question of the evening of how does science use your own body and your own immunities to then fight something that we have? And so that's loaded, and I know it is. So feel free to again, there's going to be some piggybacking on here. But how does one even think to start that way?
Yes.
With your own body that
Yes.
you feel is, there's malfunctioning going on, but let's use some of your own body to heal yourself.
Yes. So let me start with some history.
Okay.
About 30 years ago, the scientists recovered a molecule that's called interleukin-6. And they noticed that when they give this molecule to patients with kidney cancer or melanoma, that would stimulate the immune system, and the cells of the immune system will kill those tumors. However, the success was not that great. It was happening only in 10% of the patients. So 20 years later, we found some type of immunotherapy for prostate cancer that your blood is being taken out and then sent to a lab that enriches with some proteins of the immune system. And then this thing comes back to your blood and gives you a benefit.
So end stage and beginning stage is the fact that it's your own blood,
Exactly.
boosted up,
Yes.
given some extra spidey monkey stuff, and now it's back in your system.
Yes.
And your system accepts it beautifully because it's your blood.
Exactly, and that has the property to attack your prostate cancer.
Okay.
So these are like two examples of different forms of immunotherapy. What Dr. Albino was talking before is like another approach of immunotherapy that you find somewhere in the pathway of the immune system, something that if you block it, then it has the ability to fight and kill the cancer. And this is the thing that's happening more recently in the past 4 or 5 years. And that's why we have a lot of benefits, not only in lung cancer, small cell and non-small cell, for the small cell in the later stage, but also success story in melanoma, in kidney cancer, in prostate cancer. So right now we can talk about personalized treatments according to somebody's stage and according to the mutation status, who has higher chance to benefit from immunotherapy. For example, the hot topic right now in lung cancer is something that's called total mutation burden. So if you have a lot of mutations, let's say bad cancer, a lot of mutations, you have a higher chance to respond to immunotherapy.
Which makes perfect sense.
Yes. So right now we're in the process to find which of these immunotherapies are good for which type of patients and become more specific.
Okay.
Instead of throw like chemotherapy on everybody or radiation on everybody.
Okay. I have another question to ask you, but I do want to ask the guys in the back. Mario, if you can cue up the slide that you were talking about, because I'm going to ask you about the different types in a minute. Dr. Valilis, I feel like I've heard about this superstar, interleukin-6, for many, many years.
Yes.
And there was a gentleman, actually my very first boyfriend, so how old am I? 18 years old. And his father had kidney cancer, but then was treated with interleukin afterwards for white blood cell count to reestablish the white blood.
Reboost, yeah.
Yeah. So how does that work, and how did it work? Let's say that was 30 years ago.
Yes.
And into how it is integrated into this type of therapy now, because that fascinates me, where it's come in 3 decades.
Yes. So honestly speaking, this was a very fascinating treatment, and it will work for a few period of time for most of the patients.
Okay.
But in about 6% of patients, it was a home run. So we had patients with kidney cancer, renal cell carcinoma that got the interleukin, and I even have friends who got this 30 years ago, and right now they're survivors.
Oh, nice.
But only 6%. And most of the patients had a lot of side effects, but the one who made it, okay, they are good stories. The way it worked is it stimulated the immune system to make more of this interleukin and interferon and other products that will attack the cancer cells and kill them. It worked very well if somebody had lung metastasis in the lungs. It didn't work for everybody. So that was the initial stimulation to study the immune system more and find out, other parameters of the immune system that would work. But interleukin-6 was the first success story.
Interesting. And
Now,
that's
if you ask me,
yes,
why they went to kidney cancer or melanoma?
Yeah, why did they?
Okay, we knew from 50 years and before that these type of cancers, when they started growing, a lot of cells of the immune system were attacking them. So they saw that in the lab and say, how can we potentiate that? How can we make that stronger? And that's how they found interleukin, and it worked.
And this, I talk about this with oncology shows all the time because I feel like, yes, we do certain oncology shows every single year, and never is it the same show because there's always something new to be discovered. Dr. Tano, I'm looking at you, and I got the nod that the screen is ready to go. So let's pull up the screen that Dr. Tano has, and if you could, and again, every doctor is free to go through here, but explain to the audience at home, because this is what they're seeing now, what types of different treatments are we seeing here?
So this is just a brief summary slide to go over different kinds of immunotherapy that are out there. So like we had just talked about the IL-6, so that's an example of a cytokine. So essentially causing your own immune system to be stimulated and attack cancer cells. And so that's one example of a cytokine. There are other medications that have been out. I mean, I guess I'll go to the monoclonal antibody, which is that top left. And so what that is basically antibodies are proteins that your body makes that can recognize bacteria and viruses, and they also stimulate the immune system. And with the development in the lab, they're able to basically isolate certain things on the outside of a cancer cell that antibody can recognize. So it essentially identifies the cancer cell and at the same time stimulates your immune system to clear it. Okay. So there are a couple of medications that have been on the market for breast cancer, and then rituximab for a lot of the hematologic issues. So they use that mechanism to attack cancer cells and clear it.
Okay.
I guess so we can, so briefly, an immune checkpoint inhibitor is essentially taking advantage of your body naturally has the ability to recognize things that are foreign and not attack things that are considered the self.
That are good.
Yes, that are good. And so cancer cells, they can take advantage of it. And I found a really good analogy of it. It's basically if you're at work and you have an ID badge, you know that you're supposed to be there. So the way that this works is a cancer cell stole your ID badge. And so what an immune checkpoint inhibitor does is it basically removes the cancer cell's ability to hide. Because when a cancer cell takes your ID, it basically says, no, I'm supposed to be here. Oh, excuse me. I'm sorry.
Stop touching your mic. Okay, for those at home, they heard that going back and forth.
I guess
anyway,
that's where my ID badge would go. So essentially how the mechanism of how a cancer cell would hide is that it would tell your immune system, no, I'm supposed to be here.
Right.
And so with an immune checkpoint inhibitor, it takes away that ability to hide. And so then your body can say, no, you're not supposed to be here. I'm going to clear you and take you away. And so that's kind of how that would work. A cancer vaccine, so essentially what that is it's a part of a bacteria that is placed directly onto or into the patient that creates an immune response. And so that's kind of a secondary mechanism to stimulate the immune system kind of directly. Because if you're causing an irritation in a localized area, you're calling your immune system directly there. And so that's actually a mechanism that we use to treat for bladder cancer. And so that BCG vaccine is one of them.
Gotcha.
And then I guess the final one is what Dr. Valilis was mentioning earlier is being able to remove a part of your own immune system and modify it in the lab and then injecting it back into the patient to attack its own.
That's fascinating to me.
Yeah.
Absolutely. And by the way, good job on the graphics in the back, because this was presented to, thank you very much, that was presented, and then so they took those and separated those out so we can see them a little bit better. So this idea of, and I understand this is, and maybe I'm wrong, because I'm thinking too of an orthopedic show a while back where they were going to take stem cells, do something with the stem cells, re-inject. Is this kind of the same idea, or am I way off base? I know that's not a cancer situation. This is where it's rebuilding of bone or rebuilding of marrow. Help me out here, Dr. Valilis. You're nodding,
Yes.
so I'm just going to throw that your way because I just feel like this is something that. Yes, for 30 years, but again, now there's a lot more success. I know in Europe there's a lot of trials, clinical trials going on, also quite a few in America, but just in general, take us to that world.
Yes, actually, you hit it right. The stem cells are part of the immune system. So one of the forms of the immunotherapy is something that's called allogeneic bone marrow transplantation. So let's say when a person has some type of leukemia or lymphoma, we eradicate his own bone marrow because he's sick, has the leukemia, products, and then we inject stem cells from another person.
From another person, so this is not their self. Okay, I got
So
you.
the immune system of the other person is the one who's going to attack the leukemia or the lymphoma.
Gotcha.
So this is true immunotherapy. We do that in our business, treating leukemia and lymphoma. So some people believe that if you get your own stem cells and after an injury, like some of the orthopedic doctors believe a lot in that, and even some athletes like Kobe Bryant believe a lot in that. So they feel by getting stem cells, even your own, you can boost your own immune system to heal, to heal the injury. However, we're not in orthopedic business. I just mentioned like an element of that,
Right.
and I'm not sure if this is FDA approved.
Gotcha.
But it has some good theory as a background.
Right, and that's what I was saying to Dr. Tano. I don't know if it was on air or off the air, but I feel like if we had this exact same show 5 years from now, I mean, I'm thinking 10 years, fine, but really 5 years from now, we're going to have a very different conversation. And our lovely medical students, we have, again, both, oh my gosh, I know we have Aaron back there and Nikita. So just remember this show 5 years from now, because you guys are going to be in the field doing something at that time. And where are those doctors going to be with this whole world? Because I feel like immunotherapy is going to be what we hear about in mega form over the next decade. I really do. On that note, Dr. Albino, I'll start with you, but I want all three of you to answer this. In that idea, what do you see, what your treatment you're doing, what your treatments are now, but what do you see 5 years from now, just by going to different seminars that you've see, just different things that you're reading, what your colleagues are talking about? What do you see in this field 5 years from now?
Yeah, 5 years from now, I see something, and Dr. Valilis touched on this earlier, the goal of personalized medicine. It will no longer be, you have this stage, therefore you will get these treatments. It will be, your particular tumor tissue has these mutations. That makes it unique. So you need a specific treatment that will not be the same as the next person with the same cancer, quotation, and I say that in quotations because we know that there is such heterogeneity, and by that I mean just a lot of variation in different tumors in different people. It depends on your ancestry, it depends on your age, it depends on a whole host of factors which makes these tumors so sophisticated, and with traditional treatment it has been so difficult to manage. So that's where I see this coming, and that goes to what Dr. Valilis was saying earlier.
And Dr. Tano, I'm going to ask you, because I'm going to try to bring this back down for a minute, on how these diagnoses are done. You know, when you've got certain types of cancer within subcategories and subspecialties, how is all of that then diagnosed? Are they, but biopsy is the beginning step. But then there's all these other tests to figure out exactly what type of cancer you have that Dr. Albino was talking about. It's so specific.
Yes, and so actually Dr. Albino had mentioned a little bit earlier about as far as being a candidate. So at this point in time, there are a few medications on the market that you may be a candidate for depending on how well your tumor expresses a particular kind of protein. And so so being able to test not only to see if your tumor expresses this particular protein, but also how much. Because let's say, for example, there is an immunotherapy that is now considered first line if you have greater than 50% expression of a particular protein. And you can get that immunotherapy by itself as the very first thing that you see. And that's what you, to kind of touch back on the question you had asked earlier about where do you see this going, to me, I feel like that is how the cancer future is going to look like. We now are getting approval for these treatments in the metastatic setting, in patients that are looking for for treatments that may be considered, aggressive or already metastatic in stage 4. But now I think we're going to be getting more and more approvals where we be able to use it earlier. So it won't be in a stage 4, but it may be in a stage 3 or a 2 or 1 in the future.
Okay.
We might be able to use these therapies sooner.
And what type, as you're speaking, what type of cancer do you have in your head as you are answering that question? Like a breast cancer, because I feel like breast cancer month just happened, so I feel like that's in my head. The reason I'm asking that is there one biopsy and then maybe another biopsy and then another biopsy? It's like, what tests are done? You're telling me the outcomes of what they would be, but what is physically done with the patient in the office or in the clinic?
So it's mostly with the original tumor biopsy.
Okay,
and
gotcha.
resection, they're able to send that tissue to the lab and then test to see how much of that protein is available.
Okay.
How much of it is around. So, yeah.
Okay, that's what I was getting after. Got a couple of questions here from the audience. This one, I'm going to honor this one. This is a live Facebook question and wants to know how we can improve our immune systems in terms of food and lifestyles, and if we ever need to access immunotherapy in the future. I think that's a great question because, again, we're looking at using our own bodies as defenses. What can we do to keep ourselves healthy? I see it may be a generic question, but in this world of cancer therapies, anybody want to take that question? Dr. Albino, you're kind of giving me the nod, so you get that. Dr. Valilis? Okay, you got the smile. Dr. Valilis, that's yours.
So, what is the immune system? It's like a cluster of proteins that attack bacteria, cancer cells, etc. So, my answer is if somebody is quote-unquote healthy, which means non-obese, non-smoker, then he has a chance to have a good immune system. But there are no food or products to boost that. We have a lot of claims.
A lot of claims. I'm glad that you said that.
Yes,
and
by
we're going to talk
products,
about that. Right.
by products not approved by FDA, not controlled by FDA, but there is no proof that they improve the immune system. However, what I would like to say is there are certain illnesses that the immune system is very low from the beginning, from the time the patient has no symptom, like multiple myeloma, chronic lymphocytic leukemia. These patients have weak immune system from the beginning. Okay, for these people, there is medication to boost the immune system. So these two illnesses have low immunoglobulins. So what we do, we give the infusion of immunoglobulin to boost the immune system. And this is approved by FDA, and we do that in common practice.
And that's specifically, and the reason I want to say this too, because there are a lot of claims out there, like you said. So this is a discovered, compromised immune system already.
Exactly.
And this is why specifically you can give these types of boosts. I just want to make sure that the audience gets that clear, that you can't just go to the local vitamin store and boost your immunity.
Right.
Okay. And I didn't mean to stop you. I know that you were going to go on with something else with that too.
I wanted to expand on what Dr. Tano said before. She mentioned many times specific protein. Okay, so for our viewers, the specific protein we're talking about is PD-1, PD-L1. So a lot of patients know that and they're educated. So when we take the biopsy, for example, among other things, we check for PD-1, PD-L1 to determine if somebody will have benefit. Because the other thing happening is a lot of these products are being advertised in the television and magazines.
Right.
So everybody comes to the office and say, give me this for any type of cancer.
Exactly.
Why? Because I saw in the TV. Okay, hold on a minute. We have to do our job. We have to check your biopsy. If you have this marker, yes, you're a candidate for this medication at the proper stage. Not right away, maybe after the first treatment fails. So I would like to make things like practical.
Right.
Yes.
And I love that you said that point. We do, when I remember, I do this on the show because the internet is a beautiful thing, but it's also a very dangerous thing. So Do you have, off the top of your head, several websites that you use? The ones that I use for the research that I do on this show, I use WebMD a lot because it's a variety of different things. But again, it's a peer-reviewed website. For oncology, I use cancer.org, which is the American Cancer Society. For Cancer is the other telephone number, but the National Cancer Institute, just look that up in your search engine. That's also a peer-reviewed oncology site. But are there any other sites that you all use or that you know that we can give to the audience that they can look at versus, hey, I had this operation and this is what bad happened to me. And this is, I can imagine the folders of stuff that you guys get. But any ideas of websites that you can throw out there, Dr. Tano?
So yeah, I would agree. For patients, it would be good. The American Cancer Society, of course, the NCCN.org. So basically, they do provide guidelines for physicians, but there's also good educational material on there for patients, just to understand what their disease is, and good graphics and everything. So that's another good one to give.
Nice. Yes, Dr. Albino, you were
I just wanted to say by NCCN she means National Comprehensive Cancer Network, just in case.
That helps. National
acronym.
Comprehensive, because we'll do all these at the end of the show too.
That is definitely an excellent source.
And for those of you, if this is going a little bit too fast, and it goes fast, you can rewatch the show again on kcostv.org. Go to programs, local programs, find the El Paso Physician. And you can also go to the El Paso County Medical Society website, and that is epcms.com, because I know these go so fast, and sometimes you can't catch them. And if you are a Facebook user, we are streaming live, but also later on, you'll be able to find this show again on KCOS TV. Oh my gosh, I forgot my train of thought. Shoot. Anyway, so let me go on to the questions I have here. We were talking about FDA-approved immunotherapies. You just talked about some FDA-approved boosters for people that have very specific issues with their immune systems. Are the therapies that Dr. Tano talked about earlier when they were on screens, all of those are FDA-approved? And are there still some, I'm assuming there's quite a few on the horizon that are not FDA-approved in America, but might they be approved in other areas? Because I have a question here, too, from the audience. Dr. Albino, you were nodding with that one, or who should I throw that one to?
I can take that one, actually.
Dr. Tano, excellent.
So yeah, there was actually one that came out this week for metastatic breast cancer. For those that are triple negative, it's research from Europe.
Okay.
And again, it was a phase 3 clinical trial that looked at a very specific subset of triple negative breast cancer patients. They did express PD-L1 greater than 50%. And they went ahead and they gave them a monoclonal antibody that addressed that. And essentially, they found that those patients did better. And so it's not FDA approved in America, but I think at least for breast cancer, there is at least now data that shows that there can be something in this area for treatment as far as immunotherapy.
And Dr. Valilis, take this as a compliment. You're the oldest guy on this table.
Yes.
So, with FDA approval, Dr. Albino is laughing, but there's a reason for this. FDA approval, let's talk, and not too expanding on it, but the approval process and how many years it takes for something to be approved. You would know, I'd imagine, more than anyone else on this table, what that process is about. That way people at home are like, well, how come, there's a question here about Cuba, I'm going to ask in a second, but why is something approved in Cuba and it's not approved in Germany, but it's approved in Denmark? How is that the case? So how does that all work?
Yes. Most of the medications for cancer are approved in the United States. Allow me to say, United States is a pioneer in the world. It's a very small exception that something will be approved outside of United States.
Good to know.
And the reason for that is, here there is a free market, and there is a good, good way for profit. So everybody would like to develop his medications in the United States. And
they have to prove that it works.
Exactly. So in order to prove that it works, it has to be certain research that will define the benefits versus the side effects. So the reason that FDA might take 2-3 years to approve something is they want to make sure they will approve a medication that it's not public harm. It's not harmful to patients. So that's the reason, and I can tell you for the past 2-3 years there is an expedited way to get the medication approved by FDA sooner than before. Now, in the meantime, before the medication is approved, it's under clinical investigation. So there are several places in the United States, that, including El Paso, that a research is being done. So patients can participate in clinical trials. Yes, I know there are obstacles, there are, transportation issues, but that's how we study a medication, to accrue several patients in the research phase before FDA says, yes, it's proven, go ahead.
That makes sense to me, and I like when that is explained, because that is attached to, yes, it's FDA approved, and then it kind of gets thrown away. It's like the good housekeeping seal of approval.
And over the past 20 years, we've had a couple of instances in oncology that the medication was approved, they found the side effects were too many, and the FDA pulled the market. Exactly.
Yeah. And again, that's a beautiful way for something to work in a free market.
Yes.
And that's the way it should work.
Yeah,
yes, Dr. Albino?
Yeah, I just wanted to clear up, and for our viewers, clinical trials are done when drugs have already been proven to work in the laboratory. And by that I mean, we don't just take a molecule and say, let's try it on a person, see what happens. These medications are first tried on cancer cells that are isolated. We take samples, blood samples from people with cancer, and obviously these cells are incubated with these molecules that become the cancer drugs. And we see that they start killing the cancer cells effectively. And that's what we call early phase trials. And then that's when they're tried on people first at very low doses in what we call early phase trials to determine the safety of that drug. Then once that's established, then it starts to be done in these later phase clinical trials, which our patients can participate in. But these drugs have already been tested, and we know they work. We know that their side effects are not as severe once they've gone through the earlier phases of testing. So that's pretty much just to clarify.
Of clinical trials, I feel like I personally, if there's an issue with me and there was an option to be in a clinical trial, are there ever issues of not enough people signing up for clinical trials, or is it just the opposite?
No, there's always issues.
There's always
for
issues.
signing people up for clinical trials. Different obstacles, and Dr. Villegas already touched upon them. There's some paperwork that you need to go through, which some people may find uncomfortable. There can be transportation issues also, which Dr. Villegas already mentioned. Some people are frankly afraid because they feel that there might be experiments going on with them, and people don't like to feel like they're being used as guinea pigs, so to speak, which unfortunately is something that has been done in the past throughout history. That is not the case with clinical trials, of course, but there is a bridge that we need to cross, so to speak, in terms of education, that these drugs have the potential to be better than the standards of care that we already have, and that's why we encourage people to enroll in them, because we know that they have been successful in the lab, but we need to prove that they work on people and show it to the FDA in black and white in numbers so these drugs can be approved. So the clinical trial has the potential, the patient has the potential to receive a drug that is even better than the standard of care.
And that's where I would think this would be definitely an opportunity. So if you get asked to be part of a clinical trial, again, we have that disclaimer at the beginning of the show for that reason. I'd say jump on it, because you never know what's there.
Absolutely.
Before I go further, Dr. Villegas, this is for you. I know you can't see it, but what it says here is that I'm not going to say I am going to say his name because he put his name on here. David Clark, who is a cancer survivor, really, really wants to thank you. You were his doctor and you saved his life. So every now and again when we get one of these, I talk often about our doctors on the show. They're people too, because I think sometimes you go to the doctor's office and you kind of just check out because it's like you're a machine up there, you're a doctor. So I thought that was a beautiful thing. Actually, I'm going to throw this out to anybody. I have not heard about this at all, and sometimes we get really odd questions. This is all that we have to go by, so this is our disclaimer as well. A caller has heard about a vaccine used to prevent lung cancer. And this is something that they were talking about in Cuba. I haven't heard anything about this. Is this something that you have heard about at all? I thought I'd try to honor the questions from the audience, but it is a question from the audience. Anybody have a clue what this might be?
Actually, I haven't heard anything.
Okay.
But what I can tell you is every day, if you read like the international press, let's say all over the world, every day there are claims a new medication will, cure the cancer, and, the other companies, some Mutation. So everything is straightforward. If something is working in the lab or in the animals, it will be placed in clinical trials to prove it.
Right.
So maybe I don't know about this specific question, but I'm very skeptical.
Yeah. And that's, again, why we like to give out, again, some of the websites we have. NCCN, which is for the National Comprehensive Cancer Network, is that correct? American Cancer Society, WebMD. When it's real, you will be able to find that on these websites and when they speak specifically to doctors. So before giving hopes up, that's the case. Dr. Villas, you get to take that home, put it on your bedside, make you feel good in the morning. Another question here from the audience, also not something I've heard about, but the question is, with lung cancer history, is there a correlation between tonsil removal, development, and lung cancer? And I feel like I remember interferon being something that the tonsils produce, and we talked about interferon a little bit earlier. I don't know if this has anything to do with that question, since we brought that up. And again, if this is not something we can answer it because this is all the information we have. Dr. Valilis, I'm going to throw that your way if you want to take it. If not, we'll move on. Okay.
Absolutely. So, any textbook, any website will tell you what are the risk factors for lung cancer. So apart from what we know for many years, smoking, radon exposure and other chemicals, asbestos, yes. Now for correlation between tonsils and lung cancer, I haven't heard anything.
Okay. Okay. The last thing I remember, and again, this was years ago, it was just the interferon that tonsils produce. Question here, actually this is a question that nobody likes to answer. Let's talk about insurance and the fact that immunotherapy is becoming more and more accepted in the world of insurances. Are there issues now with certain types of immunotherapy because it's very targeted? I'd imagine insurance companies do want to pick that up, but it is a question that the audience wants to know. It's a hard question for doctors because I know that you guys are not the office managers and have to deal with that. But in general, immunotherapy, and I know there's many types, and I'm looking at Dr. Tano because I haven't talked to you in a while. But in general, how do insurance companies like the idea of immunotherapy?
So as long as there's an FDA approval, we should be okay. And I say that with a caveat because every insurance company is different, each plan is different. But one of a hard and fast rule is if it's experimental, they're not going to cover it. So if there is an FDA approved setting where you can receive immunotherapy, it should be okay. And as physicians, we end up having to provide documentation to show, you know what, it is FDA approved and this is why. But that's sort of the biggest caveat. And I think, hopefully in the future as more get approved, it'll be easier because it's still relatively new. Insurance companies are becoming more familiar with the vocabulary and different things that are out there, so I think it will get better, but that's probably the easiest way to ensure that it will be approved.
And that makes sense. So let's go back to the whole clinical trial issue. How are clinical trials usually funded? Because they're not experimental, but they are. They've been proven in certain areas, but not necessarily on the human population yet. How, in general, are clinical trials funded? And I'm just throwing, Dr. Albino, you're a clinical trial guy. That's what happens. You get assigned certain things during the show, so you're a clinical trial guy.
Yes. Well, the truth is that a lot of the clinical trials that are going on today are actually funded by the pharmaceutical companies that produce the drugs.
And that makes sense too, of
yes.
course. Okay.
It makes sense, but it also presents the question of, is there a conflict of interest here? What is the purpose behind the development of the drugs? The truth is that they are funded mostly by the pharmaceutical companies, and obviously they do have the goal of profit in mind with their drugs. However, clinical trials, especially when they're funded by pharmaceutical companies, are tightly regulated and monitored by companies such as mainly the FDA. They look at their data very rigorously, and they have very high standards, and they require an extensive amount of documentation that needs to be in place. So,
but you want that, and I guess we joke about that while we're on the air, but I would love for you to go into a little bit why that documentation is so important, because our grandkids are really going to benefit from that, or however you want to describe that, because there's a reason for that documentation.
Absolutely, and documenting, for example, adverse events. We have to document not only serious adverse events that result in the patient hospitalized or worse, we also have to document even the most minor adverse effects during the development of the drug. And the reason for this is that these treatments are going to potentially be given to human beings in mass. So you have to have the highest of standards in order to get a drug approved, and for every single physician to have it at their disposal and give it to their patients.
And so that's such a beautiful thing. I mean, again, it may be, you know, every good thing happens from some hard work, and sometimes there's, you know, it's just so important.
Let me expand a little bit.
Yes, please, Dr. Valilis.
I agree 100% with Dr. Albino. Most of the studies funded by pharmaceutical companies, but these are like international studies all over the world with close monitoring, so heavily regulated. Also, a certain percentage of clinical trials is being funded by the government. So, for example, our professional organization, American Society of Clinical Oncology, every year has like a campaign to convince the budget officer to allocate more money for clinical research. And this is like the research that might not be so interesting to the pharmaceutical company, but it is very important for the public. So, for example, you have so many immunotherapies for lung cancer. Okay, which one is the best? Maybe the government has to step up and say, that's how you're going to do a clinical trial. So it's both. And we believe that the public sector and the private sector work very well. One needs the other in order to promote the science and help the patients.
You know, public-private partnerships are the best in almost every situation. I couldn't agree with you more. We're at about a 10-minute mark right now, and what I usually do at the 10-minute mark is, if there's something that we have not talked about yet this evening that you all really want to talk about, I want to stop all these questions and really get to that. So, Dr. Tano, I will start with you. Even if it's something that we touched base on, but you thought, you know what, I'd like to explain that a little bit more. Is there anything this evening that you feel like really needs to be expanded upon?
No, I think we've done a pretty good job as far as, you know, touching base on all the major points, but going back to what Dr. Valilis had mentioned earlier about seeing things on TV and seeing things that are advertised, always take things with a grain of salt, and also know that, you know, these medications, they become approved in a specific setting. So just because you have lung cancer doesn't mean that you're an automatic candidate for immunotherapy, because that hasn't obtained approval in your particular case. And so it's always just mindful, just throwing it out there, just to be careful. You can come forward with, you know, questions, and it's always good to have a good relationship with your oncologist to ask that question, but be receptive to, well, we won't be able to give you this because of X, Y, and Z reasons. So
And I would say, and I've heard many doctors on the show, that when you do go to your doctor's appointment, whatever doctor's appointment that is, maybe take somebody with you, because sometimes it's 2 ears. And I was joking about the fact that doctors are people too, but I really feel like the patient gets in front of you and it's like, it's the white coat syndrome. It's like you said everything you were supposed to say, but they just completely check out. So sometimes with that explanation, take somebody with you that you know kind of can comprehend these type of things. Dr. Albino, anything that we would that you'd like to expand more on tonight?
Yeah, absolutely. We talked a lot about immunotherapy today. One of the things we didn't expand upon is the low side effect profile of immunotherapy as compared to traditional chemotherapy. For example, some patients with advanced stage lung cancer, the only available treatments we had up until a couple of years ago was chemotherapy, which does have a lot of toxicity associated to it, as most people know. So now it's a matter of evaluating with immunotherapy. So a lot of people would say, well, I'd rather not get chemotherapy because it's going to make me feel really bad. But now you can have the benefits of chemotherapy, expanding your lifetime without those serious side effects. So for a lot of people that are hesitant maybe to receive treatments such as chemotherapy, they should now look at these new options and say, well, maybe there's something different for me. I could be a candidate for something that will give me that benefit without giving me those severe side effects, because the side effect profile of immunotherapy is very different from chemotherapy. Very limited
in the
side
office,
effects.
is that something that's automatically spoken about within the conversation? Does the patient need to kind of know to ask that? And I know it changes with time too, as as people get more comfortable.
Absolutely. The conversation about side effects is maybe the most important one, aside from what your diagnosis is and what are your treatment options. The next most important thing is talking about what those side effects are, and yeah, we have that discussion pretty much with all of our patients before they receive any treatment, and they have to consent to it. And in order to consent to it, a discussion regarding the potential side effects must be had. And that is definitely pretty much the most important thing that we as oncologists have to discuss with our patients.
So here's another question. It's something that I was talking about with Dr. Tano earlier too. When you are discussing treatment options with the patient, I feel like, and I love this about El Paso, that you do have 1 or 50 family members coming with you to the appointment. Are you usually part of the discussion with the patient and their families? Do you kind of give the ideas and the pictures, they go away, they make a decision, they come back, and I guess it's different all over the place too, but in general, and Dr. Villegas, I'd love for you to answer this too, how is that human part of deciding what course of treatment we're going to take, how does that occur?
Yeah, very good question. Usually I, as well as my colleagues, encourage patients to come with at least one family member. Sometimes it can get a little confusing if there is 5, 6, or more family members.
Exactly, and I guess that's the point I'm trying to make.
And then there's contradicting opinions among all of them. At the end of the day, the person that needs to make a decision is the patient. The family members are there for support. I always encourage my patients to take in the information. The family members listen to that information, and then after that, I tell them, go home, think about it, discuss it with your loved ones, listen to everything they have to say and what their opinions are, but at the end of the day, it's your decision.
Right.
But you take into account their feelings too, but you're the most important person. You're the one that's going to go through this and going through all this, so it's your decision at the end of the day. So that's usually how I handle that.
Yeah, and El Paso, again, is such a beautiful family-oriented.
Correct.
And Dr. Villegas, you were smiling and nodding, so I know you've got a couple of stories, but in general, what would you like to say to that effect?
Yes, I agree exactly with Dr. Albino. And what I've noticed is that most of the family members will say, okay, you're not demented, you can make your own decisions, we'll support you.
Nice.
So I don't see that much of, paternalistic behavior, I'll tell you what to do. So this is good, and even the patient admits that, okay, I'll think about that and you help me. What I wanted to say also, expanding from Dr. Albino about the side effects, is that some patients cannot take immunotherapy. So we want to make that clear to the audience. If somebody has some illness of the immune system, like rheumatoid arthritis, lupus, psoriasis, some type of colitis, then there is a chance if this person takes immunotherapy, he's going to get really bad.
Interesting. I didn't even think about that.
Yes.
Right, of course. Yeah.
So it is important before we tell the patient, yes, we would like to do that, we ask, the history, and sometimes we have to reject patients from that. And the other thing I wanted to say is immunotherapy is not a cure for the cancer.
Right.
It's one big step forward. Yes, we have more options for our patients with less side effects, but still the majority of the patients will not respond to these treatments. So we need to find more treatments. That's why we keep doing clinical trials to find medications that today they're approved, but 5, 6, 10 years ago they were experimental.
Exactly.
So that's how we make progress, if we encourage our patients to try new medications, to find new drugs.
I don't have time to go to another question, but I would like to revisit something that we talked about earlier, and you hit on it beautifully again. With the idea of, and let's just say there's 100 patients, just to make it an easy number, and of those 100 patients, let's say that there is now a large cell lung cancer or a non-small cell lung cancer. Say there's 100 patients, and just throw your best guess out there of who might be eligible in all the ways that they could be eligible? Would it be 30% of that population? Would it be more than that? And it's a hard question to ask, but I'm just trying to think of where we're going from today.
Okay, 80% of these patients
80%.
will be eligible.
Okay.
But that doesn't mean they will be cured.
Right.
They will respond to the treatment for several months or many years, and there is a chance that 20% might be a home run.
Okay.
But, that's what we're talking about.
So 80% would be eligible. About 20% would be a home run.
Yes.
And then we've got that 40% that, hey, this may work for a while, maybe it will come back, maybe we'll have to try something else.
Yes.
Okay, beautifully said. Again, I know we have a couple of minutes here, so I really want to give out some of these websites. The American Cancer Society is American Cancer Society. It's cancer.org, pardon me, that's their website. The National Cancer Institute, you can just look that up in the search engine. WebMD. NCCN, and NCCN stands for, again, the National Comprehensive Cancer Network. And then I think Dr. Albino has suggested, or somebody has suggested, the American Society of Clinical Oncology. So if you're able to watch the show back again, you'll hear those again. The telephone number at the El Paso Cancer Treatment Center. Sometimes it's just nice to call and say, hey, this is a question, and you may be directed to a phone number or a website or somebody there on staff. But the telephone number here locally, 599-1313. And again, that's the El Paso Cancer Treatment Center here in town. And the bigger envelope of that is Texas Oncology. We've been talking tonight about immunotherapy, and it's very specific on targeted oncological therapies, which we're going to hear an awful lot about in the next couple of years. I know this is November. My gosh, Thanksgiving is next week. We heard an awful lot about breast cancer in October. We heard quite a bit about prostate cancer in September, and we've got all kinds of other shows coming up in December as well. So we appreciate you staying tuned. Again, I want to say thank you again for Texas Oncology, to the Texas Tech Paul L. Foster School of Medicine. Today we have had Nikita Wolf. We joked about that before the show started, and Aaron Pines, who's here every month, it seems like. So thank you so much for being here. Next month we will have shows in December, not around the Christmas time. There's one in the week prior to the Christmas time or the Christmas break. So again, kcustv.org and epcms.com, two places you can watch a show back. I'm Catherine Berg. I so appreciate you watching. All of us here are volunteers on the El Paso Physician. Good night.